Thank you very much, Eric. Thanks, guys, for being here. I hope this will be a informative and helpful talk. Jesse, Wenger, and I put this talk together with the help of the lung subgroup. All right, so the goal is to review normal structure and function of the right ventricle. We're going to talk about where a point of care approach will fit in assessing right ventricular function, and apply that more specifically to pulmonary heart syndromes. We'll also talk about briefly about lung ultrasound and where that fits in this clinical setting. We'll briefly discuss DVT and the role of point of care assessment of that. And we'll talk about the limitations that we have with point of care assessment of the right ventricular function. We're going to try to make this a case-based setup. So the case for this talk will be a 15-year-old obese female with some history of asthma. She shows up with fever, chest pain, shortness of breath, and mild hypoxia. She tried albuterol at home. It didn't help. She remains hypoxic, tachycardic, hyperthermic, but not febrile. She's in some distress on exam, and your chest x-ray is normal. So I'll give you just a second to think of some things that could be going on here. What would fit in our differential? And this is what I came up with would be the most likely cause of her presentation. So this gives us a framework through which we need to think. Pulmonary embolism, pneumonia, asthma exacerbation, fusion, either pleural or pericardial, and then pneumothorax. So based on what are the differential that we've come up with based on this patient's presentation, how can we apply point of care ultrasound? I think point of care ultrasound makes me a better doctor because I have to think, what am I looking for with my ultrasound? So it makes me form a differential diagnosis before I just slap the probe on. If you're not thinking about what could be causing the problem, then you're not going to find it. Further, point of care ultrasound doesn't replace anything in our workup. It's a supplement, a very powerful supplement to the workup, but it should just be used to augment and support and work through your differential. So the question that we're asking with our ultrasound in this patient who shows up dyspneic and hypoxic is there a pulmonary parenchymal etiology that we can find to explain our presentation? If there's not, then where do we look? Is this a PE? Can POCUS help us make that diagnosis? And if it is PE, what else can we find? What else should we be looking for with our ultrasound? So this is not a lung ultrasound talk, but we are going to briefly run through how we might apply lung ultrasound in this patient because it's going to be where we start in somebody who comes in with hypoxia and dyspnea. So a four-quadrant approach is pretty standard in each hemithorax, and it's kind of what we go through here. So this slide is an example of normal lung ultrasound. So you have pleural sliding here. You see nice, a couple of Z lines that don't go all the way to the bottom of the frame and nice A lines there. So this is probably what we would expect. This is a normal lung ultrasound. You can see at the end of the clip, the diaphragm comes into view, this double line structure that's crucial to identify. So you know when you're in the thorax and when you're in the abdomen. This is a nice example of that. So this is normal lung ultrasound. A few Z lines here, lung sliding, A lines here, and the diaphragm coming into view at the end of the clip. The next slide is an example of abnormal lung views. So this would, if we saw this in our patient, we know there's a pulmonary parenchymal etiology for her symptoms. So here we have B lines coming, we have lung sliding, an area of confluent B lines, relatively diffuse in the non-probe marker side on this view. And then you can potentially make, a subpleural consolidation comes in at the end of the view, right at the end of the clip right here. And then this is an example of pleural effusion. You can see diaphragm here. Cranial to the diaphragm, you have consolidated lung and pleural fluid. Within that consolidated lung, you have air bronchograms right there. So diaphragm, pleural fluid, air bronchograms. So if you saw this on your point of care ultrasound, you would have your diagnosis for this patient. But we're going to talk about the right ventricle. So the right ventricle is a pretty low maintenance chamber under normal circumstances. It's a thin, compliant, low afterload system. It's crescent shaped and much smaller than the left ventricle. It does great with volume. It does poorly with pressure. So if the afterload conditions are increased, the right ventricle is not going to rise to the occasion. It has no or very little contractile reserve, so it dilates almost immediately when faced with a larger obstacle than it's used to. It's very distensible, so it's going to dilate quickly. Because the RV contracts in several different ways, that's one barrier to easily quantifying its systolic function. So the free wall contracts inward and the chamber shortens longitudinally. And then you also get a not insignificant portion of right ventricular systolic function from the left ventricular systolic efforts as well. You can see the diagram in the right lower corner here. Part of the way that the ventricles wrap around each other also limits how successful we can be in our right ventricular systolic assessment. But we're going to talk about some ways that we can work through this. This is a list of pulmonary heart syndromes, which could be useful or which could cause pathology in the right ventricle, could increase the afterload conditions and make that RV work harder than it has to and cause dysfunction and failure. So this list here, primarily thromboemboli, but also some cardiopulmonary interactions and extracorporeal associated complications. So we're going to start with a qualitative assessment of the right ventricle. So right now, we're not talking about our case. We're talking about, we're going to go through and learn some content. The goal is that this is helpful to both new learners and more advanced learners. So we have some content in here for everybody. And I think the qualitative assessment is what should be the bulk of what we take away from this talk. It really is pretty high yield and can be quite helpful in several different clinical situations. So the image on the left is an apical 4-chamber view. Really, we're seeing a lot more of the ventricles in the atria in this view, but the goal of this, of the qualitative assessment that we want to make under normal conditions, the left ventricle to right ventricle ratio should be 1 to 0.6. You want to see the left ventricle form in the apex, and we can pretty much see that here, but the left ventricle should be the dominant chamber. And that's a pretty easy qualitative assessment to make in this view. It's not even a great apical view, but we can see what we need to see from this view. This is a parasternal long axis. So again, for the new users, this is going to be putting the probe just to the left of the sternum and angling and pointing the probe marker towards the patient's right shoulder. The qualitative assessment that we can make about the right ventricle and other chambers in this view is that roughly we want to see a 1 to 1 to 1 ratio, RV to LV outflow tract to left atrium. And if that ratio is not maintained, then it's potentially indicative of some pathologies that's causing that violation. We're not going to be able to make great assessments of the right ventricular systolic function in this view, but we can. If this was taking up more like half the screen, that would be an potential evidence for right ventricular dilation. So this slide is evidence, are examples of some pathology. So we just talked about parasternal long axis view. So this is left atrium, left ventricle, small left ventricular outflow tract, and a large right ventricle. This doesn't follow the 1 to 1 to 1 ratio. This looks like 2 1 to 1. So we've got potential evidence of right ventricular dilation in this parasternal long axis view. And then the image on the right-hand side of your screen is another apical view. We've got a little bit of the atria. So this is left ventricle, right ventricle. You can see in this image, the right ventricle is the dominant chamber. The right ventricle is forming the apex, and this is like a 0.5 to 1 ratio. So right ventricular dilation, potentially some right ventricular hypertension, but all we can really say here is that the RV is larger than it's supposed to be. More qualitative assessment. This is a parasternal short axis. So from our parasternal long, we would rotate the probe 90 degrees clockwise, now with the probe marker pointing roughly at the left shoulder. So the image on the left is what we expect in normal right ventricular conditions. This chamber is the left ventricle. This chamber is the right ventricle. This is also called the breakfast view. Like this is the donut, this is the croissant, this right ventricle is the croissant wrapping around the donut. And what I want you to take away from this slide is the nice rounded septum here. This is how this should look. This is the higher pressure chamber with the septum bowing into the right ventricle, but nice and rounded. And then the image here, again, this is also at the level of the papillary muscles. But you see this septum is really flattened, and it's not bowing into the right ventricle at all. In fact, if anything, it's bowing into the left. So this is potentially indicative of right ventricular hypertension. This is an abnormal, this is not what's expected in a normal right parasternal short axis view at the level of the papillaries. So now we're going to move into some quantitative methods of right ventricular assessment. Again, I think the most applicable parts of this talk are qualitative, but it is nice to have some quantitative skills to add to your repertoire that can back up what you're seeing qualitatively. The first application we'll talk about is fractional area of change. This is not one that I use often. This is the quantitative method that I use least in right ventricular assessment. But so from an apical 2 or 4 chamber view. So with the from a standard apical view, if you want to just focus on the right side, you would, in most cases, rotate your probe counterclockwise until you're primarily focused on the right-sided structures. So you want to see all of the right ventricular free wall, which will also allow you to make some qualitative assessments of the inward motion of the free wall. But to assess fractional area of change, you get that view and then use freeze at the largest and smallest dimension of the right ventricle. So largest is going to be in diastolic area. You trace that using the function on your ultrasound machine, and then freeze again at the smallest dimension, which is the end systolic area. Take the difference between those and then divide by the right ventricular end diastolic area. Accepted normal RV fractional area of change is about 35%. Greater than 35% is normal. Again, this is not something I use frequently, but it is nice to know, and it makes sense why that would be a reasonable assessment of systolic function. The more widely used systolic function of the RV is TAPSE, tricuspid annular plane systolic excursion. This has definitely been adopted by adult emergency departments. They use this routinely and feel pretty comfortable with it. The idea is, again, you use the apical view. So the picture that I have displayed here is they flip this image in cardiology standard, but you get an apical 2 or 4 chamber view again, and you place an M mode line through the lateral aspect of the tricuspid valve. And really, it's just measuring. It's a quantitative measure of the longitudinal movement of the tricuspid valve. It produces this waveform, and then we measure from peak to trough of the M mode waveform there. The angle does matter. You want this to be coming down roughly from here, a straight angle. The closer you can get to up and down, the better. But this is what it looks like. And this is the measurement that you make. Normal in adults is greater than 1.7 centimeters. There's some published evidence for normative values for children. We don't have those all printed, but you can look that up easily. This is some of those values plotted out. But TAPSE is I don't think it's commonly practiced in all places in pediatrics, but it is widely practiced in adults, not just by cardiologists. The next quantitative measure we'll look at is estimation of right ventricular systolic pressure. So using velocity from the right tricuspid regurgitant jet, we can translate that into pressure using Bernoulli's equation simplified. So you get the velocity of the jet, you square it, multiply by 4, and then add that to your estimated CVP to get your right ventricular systolic pressure. We do this using continuous wave Doppler, and we'll talk about that now. So two forms of spectral Doppler, there are others, tissue Doppler being one, but the two that we're going to compare here, pulse wave Doppler and continuous wave Doppler. So pulse wave Doppler is sending and receiving by the transducer. You're able to analyze your Doppler, you focus it rather, with a gate mechanism, so you can specify where you want the measurements to take place. This is good for low velocities, but aliasing causes problems at higher velocity flow areas. So at the LVOT, so if you're going to do a velocity time integral or aortic peak flow velocity variability, this is your tool. Pulse wave Doppler is great for this. You can also do some diastolic evaluation with pulse wave Doppler. But in this, what we're talking about now is tricuspid regurgitant evaluation is going to be best assessed by continuous wave Doppler. So it's continuously sending and receiving ultrasound energy, but it is not as specific. So there's no gating with continuous wave Doppler. So you get some range and depth ambiguity. It's good for higher velocities because you don't have to deal with the aliasing. And primarily it's used for valve pathology, valve evaluation, of which I don't do much. So aliasing, a little bit more on aliasing and why pulse wave is not the best tool for tricuspid regurgitant evaluation. So pulse repetition frequency is the rate at which the transducer emits pulses. The Nyquist limit is half of the pulse rate frequency. And that's the upper limit of velocity that Doppler can be displayed. If the blood flow that you're evaluating is moving faster than the Nyquist limit, then aliasing occurs. That means that your signal wraps around the baseline and makes measurement difficult to impossible. So if we tried to evaluate a patient's tricuspid regurgitant jet, there's a decent chance that we would run into aliasing concerns and not be able to make important calculations and determinations. So we're going to apply the formula that we just learned. A 3-year-old girl with a history of TAPVR comes in with respiratory distress. She already has an IJ, that's convenient. Her CVP is 14. We get an echo or a focused cardiac ultrasound that shows a TR jet of 4.8 meters per second. So there's the formula again. We would square that velocity, multiply it by 4, and then add the CVP to give us a likely suprasystemic right ventricular systolic pressure. So now that we've covered that material, we're going to go back to the case that we started with. So we're going to apply the cardiac assessment of the right ventricle to this patient. For the purposes of this case, we did lung ultrasound. She had no pulmonary parenchymal abnormalities on her lung ultrasound. I think the nice thing about what we're going to do with this patient is that we're going to do this only using the 4 standard point of care ultrasound cardiac views. So things that we talked about, I think it was 2 weeks ago, those views are what we're going to use to assess the right ventricle. So we'll go ahead and apply what we've learned. So we're going to start in the parasternal long axis view. The image here shows the cut of why it looks like this on the screen. So this is left atrium, left ventricle, left ventricular outflow tract, right ventricle. The image on the screen that I see looks like a dilated right ventricle. This is not 1 to 1 to 1. This is dominant. This takes up about half of our field of view. So far, based on our parasternal long axis view, this patient who showed up with hypoxia and dyspnea and no obvious lung pathology for her symptoms has a dilated right ventricle on a parasternal long axis view. That's a pretty good quality image. Next, we're going to move. So we're going to rotate our probe 90 degrees clockwise and get to a parasternal short axis view. Again, this demonstrates how the plane of cut works. So this is, again, going to allow us to look at both at the level of the papillaries or the level of the mitral valve. This is going to let us get a good view at the left ventricle and the right ventricle in short axis. You can also take a look at septal position. Again, we can see septal flattening in conditions that are causing right ventricular hypertension. But it's important to get an on-axis view. Off-axis view can inaccurately create a D-shaped looking ventricle. So the best way to do that is to get a really good peristernal long axis and then rotate at 90 degrees, and you should be on axis. So this is our peristernal short axis view for this patient. You see left ventricle here. This is at the level of the mitral valve. Left ventricle, right ventricle. This is not a nice rounded septum that we saw earlier. In fact, we've got pretty significant bowing into the cavity of the left ventricle, suggesting right ventricular hypertension. So we've done 2 peristernal views. We've got some right ventricular dilation, some evidence of right ventricular hypertension based on 2 views that we've done so far. If anybody didn't get a chance to see that. It's hard to say much about RV dilation. Maybe you could, that chamber looks a little large here, but this is not the view to give you the best assessment of the volume of the right ventricle. Next, we're going to move to the apical view. So we're going to slide down kind of at the PMIs where we typically start looking. I think this is the single highest yield view for right ventricular assessment. So we're going to get a pretty good qualitative view, which would allow us to assess the LV to RV ratio. We're going to be able to get a qualitative look at the RV free wall inward motion as well as the longitudinal motion. And then this view is also where all of our quantitative tools come into play as well. So this is a slowed down apical view of our patient. And this is pretty dramatic. So this is left atrium, left ventricle, right ventricle, and a whopping right atrium there. You can see this is at the apex, but the right ventricle is forming the apex on this image. This is not obeying the 1 to 0.6 ratio, suggesting right ventricular dilation, RA dilation. This is not a normal or apical view. We have more support for the findings that we already have on our previous 2 views of right ventricular dilation and possibly hypertension. We'll run this one more time. Left atrium, left ventricle, right atrium, mitral valve, tricuspid valve. Okay, so from this view, we can also get a quantitative look at the right ventricular systolic function, at least the best tool that we have. So we drop an M-mode line through the lateral aspect of the tricuspid valve here, and this is the waveform that we get. So again, it's peak to trough. Normal adult value is greater than or equal to 1.7 centimeters. This patient has a TAPC of 1.15 centimeters, suggesting reduced right ventricular systolic function, which is what we would expect in the setting of increased right ventricular afterload. So we've got lots of evidence mounting for a pulmonary heart syndrome, increased RV afterload condition. All right, so now we're going to apply what we just learned about right ventricular systolic pressure estimation based on continuous wave Doppler estimations. All right, so this is another apical view. This is not the classic apical view, but this is right atrium, right ventricle. We've got color Doppler right at the tricuspid valve. So if our probe is here, then and we're using standard convention of blue flow is away from the probe, red flow is towards the probe, then we would expect tricuspid regurgitation to be the blue portion of this color Doppler signal. So we're looking for the blue flow. So then we can place our continuous wave Doppler in the same spot and get a velocity of the tricuspid regurgitant jet. Again, because the regurgitant flow is going away from the probe, it's going to be a negative deflection from the baseline. So what we're measuring is going to be the portion of this waveform that is below the baseline. So we get 350 centimeters per second. We convert that to meters per second at 3.5. We square that, multiply by 4. That gives us about 50, almost exactly 50. And then we have to make an estimation of the CVP. So if you have a central line, that's great. We probably don't have a central line in this patient yet. But based on what we've seen already, we've got a dilated right ventricle. We've got some septal bowing into the left ventricle. I think a conservative estimate would be 10. I think that's very conservative. This CVP seems to be much, much higher than that. But if we use 10, then that's still going to put us at 60 for an estimate of her right ventricular systolic pressure, which would be over half of her systolic blood pressure, suggesting quantitative proof or quantitative support for the qualitative estimations that we've made to this point. The next image is also done from an apical 2 or 4 chamber view. This is not something that I was familiar with before I started working on this talk, but it's called McConnell sign, and it's a regional wall motion abnormality in the right ventricle. So we'll play this clip several more times, and what you see is hypokinesis or akinesis of the right ventricular free wall with apical sparing. So this image looks like a trampoline bouncing up and down on the right ventricle. So the apex is functioning well, the right ventricular free wall is not. This is not sensitive at all for PE, but it's quite specific. So if you see this, and to be honest, this is not something that I look for in most situations, this is very specific for pulmonary embolism. So regional wall motion abnormality sparing the apex or the right ventricle, McConnell sign. All right, so we've done peristernal long axis, peristernal short axis, apical 2 and 4 chamber views. Now we're going to move to a subxiphoid view. So this patient from the subxiphoid view, we get a good cardiac view, and then we rotate our probe marker towards the patient's head, and we find the IVC dumping into the right atrium. You see a hepatic vein coming in here. So we have a dilated IVC with very minimal respiraphasic variation. This is not specific for PE at all, but it is pretty sensitive for significant right ventricular dysfunction. One other thing that we could potentially see is flow reversal in the hepatic vein, which would be more support for right ventricular hypertension or dysfunction. We're not going to talk about VEXUS here, but you could potentially see some congestive changes in this clinical setting. So IVC is not the world's greatest measure of volume responsiveness or volume status, because in this case, we don't know what the patient's volume status is, but it's probably not hypervolemia that's the primary problem. These findings support what we've seen so far, which is elevated right-sided pressures. All right, so we've got all these findings. We're pretty concerned for pulmonary embolus at this point. So if you want to look and see, is there a lower extremity DVT, this is how we would do it. So now we're going to switch probes. We're going to use our high frequency probe that we usually use for vascular access. And so a point of care vascular exam would look like this. So we're going to start just distal to the inguinal ligament, find the common femoral vein, and compress every centimeter down to the popliteal fossa. So we compress with enough force to deform the artery, and if the vein doesn't compress, then that is a positive exam for DVT. As Eric and I were talking before, there are some complexities to the issue. Is this fully occlusive? Is it non-occlusive? But a quick look could give you some evidence to further support thromboembolic phenomenon. Now, the absence of a DVT doesn't change the other findings or even change your pretest probability, but it could be a little bit of a slam dunk if you find more of that. There is some evidence that point of care studies have good sensitivity and specificity when compared to adult formal vascular studies, but these are not meant to replace those. So this is not a DVT talk this time, but just a quick idea of how to do it. So start at the common femoral vein. Every centimeter you're compressing with enough to make the artery compress a little bit. And then if you're not compressing the vein, then that's potential evidence of a lower extremity DVT. All right, so all this is with the caveat that quantitative right heart evaluation is tough for everybody, even for the experts. Like I said, the big takeaway are the qualitative looks that we can get here. Right heart strain, which is a pretty nebulous term, but to me that means RV dilation, evidence of RV hypertension, potential reduction in RV systolic function, is not super sensitive for PE. It is pretty specific. So what conclusions can we make about this patient and about a right ventricular point of care assessment? So we have to be thinking first. We have to be thinking what could this be before our ultrasound is going to be super helpful. And then we use it only as a supplementation to the rest of our evaluation. So how does she look clinically? What sort of, what do her labs look like? Anything pointing us in another direction? But then ultrasound can provide a lot of support for other things on our differential. Lung ultrasound is very sensitive. And so in this patient with a negative lung exam, that can effectively rule out significant pulmonary parenchymal pathology. Now, you may see a pleural-based lesion, kind of a hypoechoic pleural-based lesion that may look a little bit like a subpleural consolidation in a patient with a pulmonary embolus that could be indicative of a pulmonary infarct. But the most likely lung ultrasound findings in a patient with a pulmonary embolus is nothing. So we just talked about the limitations of quantitative RV measures. This is more of a guide for further diagnostic workup if we think in a hemodynamically stable patient. So if we think if like in this patient, we had a dilated RV, evidence of hypertension, maybe some reduced systolic function, and she was hemodynamically stable, then we would get the definitive test, which is probably a CTA. I think a lot of times, at least in the PICU, in my experience, patients come to us, in some cases, they come already diagnosed with a PE, and then our job is to figure out what's the risk of this patient's PE. Even in the hemodynamically or relatively hemodynamically stable patients, all the tools that we just went through can help you assess the risk of the PE and what sort of heart strain picture, in combination with things like BNP, troponin, and your vital signs. So it's not just a diagnostic tool, it's also a risk assessment tool that can be very valuable. But if this patient was hemodynamically unstable and you don't have time for further studies, POCUS in an experienced user can be a very quick and an effective tool to help guide necessary life-saving management.